Well, thank you, Jenna, and good evening, everyone. I'm Robin Toohey, Senior Director Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference, Pre-ASH, What Myeloma Patients and Caregivers Need to Know. Tonight's program is part of the IMF's Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. ASH is the annual meeting of the American Society of Hematology. It's the world's premier event in hematology where a global community of more than 20,000 hematology professionals from every subspecialty gather to hear highlights of the hottest topics in hematology. This year in myeloma, there will be over 100 oral abstracts and over 500 posters, totaling well over 700 myeloma-related updates. Tonight's call is particularly exciting as Dr. Durie will share with us his famous bottom line on what we can look forward to. So stay tuned, and at the end of our call, when IMF President Susie Novus-Durie will share with you additional educational programs that the IMF will be broadcasting live from ASH. So with that, I'd like to thank our sponsors for their support for tonight's call, Amgen, Celgene, Janssen, and Takeda Oncology. And one more thing before I turn this over to Dr. Durie, if you have not yet downloaded the slides for tonight's teleconference, please go to the IMF website at www.myeloma.org where you will be able to access the slides. And so now I'd like to introduce tonight's speaker, Dr. Brian Durie.
Well, thank you, Robin, for that very nice introduction. I'm glad to be here and have this pre-ASH teleconference. So a few things. You'll notice that the slides are numbered, and so if you're having any trouble following, I will be identifying the slides by number as I go through just to keep everyone literally on the same page. And so I'm going to be talking about what we are going to be hearing about at the ASH meeting coming up in December in San Diego, December 3rd to 6th. As Robin mentioned, this year there will be 114 oral presentations, 573 posters, and then in addition to that, there will be other educational sessions and scientific sessions, and so between 700 and 800 overall presentations about myeloma. And so if we start out with what is slide number 3, and so this is the next slide, as Robin indicated, bottom line takeaways from ASH 2016. And for those of you who have limited time tonight, this slide covers it. It will tell you what we're going to be talking about. And so there are 10 items on this slide just to summarize what are the takeaways this year. And so at the top, I have new genetics, and it is remarkable this year that almost half of the oral presentations, which are considered to be the main presentations with the most important information, about half of those oral presentations actually focus on genetics and what we call preclinical or lab-type research. But strangely enough, although these are really detailed and extensive abstracts, they don't tell us a whole lot new that we haven't known before. So they mostly confirm old ideas. Number 2, there are a lot of abstracts this year, as there were last year and a little bit the year before, on minimal residual disease, what we call MRD. And from an IMF and Black Swan perspective, we are very pleased that some of the concepts that we have brought forward over these 2 or 3 years are being strongly supported by these new research studies this year. Number 3 this year is actually something completely new. It's a word, it's a drug that we've never heard about before for myeloma. This is a drug used to treat AIDS, and so this means that it's a commercially available oral medication called nelfinavir, and lo and behold, this AIDS drug does actually have some direct activity against myeloma, but it also works especially well to improve the efficacy of Velcade. It overcomes Velcade drug resistance. So really quite exciting to have an unexpected new drug that maybe could work well. The next one, Venetoclax, is a new type of a drug which we heard about a little bit last year. It has an impact on what's called apoptosis, where in myeloma the cells don't die and disintegrate like they should, but Venetoclax triggers this apoptosis and makes drugs work better, and it works particularly well for patients who happen to have the subtype of myeloma with the translocation 1114. Next, we have Selinexor, which is another drug that we have actually heard about before. It retains the anti-oncogenes in the nucleus and has a unique way of working, and it's very exciting to see the Selinexor moving forward and having activity in patients who've gone through everything, including daratumumab or SAR compound, and so it has an unmet need possibility and also an approval possibility with the FDA. Then I will give you some little bits of updates on the Castor and Pollux studies. Those are the combinations we've talked about before, daratumumab with Revdex and daratumumab with Velcade Dex. Very, very active combos. The CAR T cells, this is the immune therapy where you actually harvest, engineer, and then give these T cells back to the patient, and these T cells are able to kill the myeloma. Very exciting work coming out of the University of Pennsylvania, and Dr. Adam Cohn has some exciting abstracts on that. Another study which is just interesting is that patients who have amyloid light chain deposition, it turns out that carfilzomib can be especially good for that, so that's helpful to know that. A small bit of information is that it turns out that your diet can influence your likelihood of getting MGUS and also the progression to active myeloma. And then finally, some clinical pearls. These are little tidbits of information that can help with day-to-day myeloma care. And so if we move forward to slide number 4, so what about those molecular studies? Well, the first session, and this is the opening session for myeloma, has these abstracts number 115 to 120, and I've listed those there for you to see, and I'll just go quickly down to show you that these are interesting data, these are new data, but really we've known this information in the past. So the Little Rock study studied a lot of patients, and they showed that the MYC oncogene is active in over half of the patients with myeloma, 54.8%. Well, this is something that we've known for maybe 30 years. They have really confirmed it at a more sophisticated molecular level. And the same is true with the next one from the Dana-Farber. Dr. Munchie and the team there, they're showing that a particular molecular signature, what they call signature number 9, is linked to active myeloma. This is B-cell genome mutator. What that actually means is that these are genes which are linked with immunoglobulin gene rearrangement, and so this is a central port of a plasma cell becoming a myeloma cell. And so again, we have kind of known that turning from a plasma cell into a myeloma cell with the immunoglobulin gene rearrangement, we've kind of known that's important, and we've been identifying that for many years. The next one is a little bit new, the fusion genes from the Little Rock team. This means that when you get translocations, when you might get like a 414, sometimes that can result in the production of a new protein, which is called a fusion protein, which can have some activity and can lead to the cells being more malignant. It turns out that this is relatively rare in myeloma that this process occurs, but when it does, it's mostly linked to the activation of the genes which are called the RAS genes. And these are genes which we're now realizing need to be focused on, because those are genes which are active even all the way to resistant and relapsed myeloma. The next one from the Pamplona team, they looked at what's called histone modifications. Histones are proteins that cover up the genes, and when they are modified, it means the genes can be active. And so again, we've kind of known that if you have histone modifications, then you will have a series of active genes. This is quite important, though. In this case, the activation of multiple genes turned out to be more common than we had expected. A lot of miscellaneous genes turn out to be active with histone modifications. And then the final item here, cereblon splicing. Cereblon is a protein which we have known affects resistance to Revlimid and pomalidomide. And again, it turns out that the splicing at the gene level is the reason for resistance to Revlimid and pomalidomide in some patients. So again, something that we've known, but maybe this can lead to a more precise testing for this in a clinical setting moving forward. So if we go to the next slide, number 5, this actually continues in with the molecular sessions, but one of them is one which is part of a Black Swan project, actually, Smoldering myeloma, abstract 235 is from the German Heidelberg group, and they are looking at patients who progress from MGUS to smoldering to active myeloma to understand, well, what happens to trigger that. And what the Heidelberg group showed pretty clearly is that the likelihood to progress is linked to the features that are present at the beginning of the disease when the diagnosis is made. The stage of the myeloma, the speed at which it emerged, and these abnormal chromosomes and molecular changes that are present at diagnosis really hold true and predict what we should be expecting moving forward. Again, they identify these genes at the bottom, the RAS genes. There are two groups, the N-RAS and the K-RAS. They seem to be quite important in determining progression and will need to be focused on for new approaches to treatment. They also identify P53, which is the 17p minus issue, and then also those histones that I was just mentioning. If we go to the next slide, number 6, diagnosis of high-risk smoldering multiple myeloma using NGF. This is next generation flow, and so this is the MRD test, the minimal residual disease test, which we've actually been developing along with the Spanish team with Dr. Bruno Paiva and Dr. Alberto Orfeo, and we have been focused on MRD testing. But it turns out that this NGF test is very, very sensitive for picking up active myeloma cells. And so if you test patients with smoldering myeloma, you can find the patients who have mixed in with the smoldering the active myeloma. And so Bruno studied 270 smoldering myeloma patients, half coming from Spain, and then he collaborated and received half of the samples from the Little Rock team. And he found out in both graphs, the red line there shows the patients who had the myeloma cells mixed in, and you can see the lines going up indicating that those were the ones who much more rapidly moved on to get active myeloma. And so they show pretty clearly that using just that one test, the NGF test, it picks up the patients with the smoldering myeloma who in addition have active myeloma present. So this single test may end up replacing the old Mayo and Spanish systems for identifying high-risk smoldering. At the same time, Bruno was also looking at patients who might have something, and if this is in slide number 7, if you go to the next slide, slide number 7, MDS at MM diagnosis, about 6.5% of patients at myeloma diagnosis have low blood counts. And this turns out to be because they have myelodysplastic syndrome. the normal bone marrow is damaged, and we call this MDS. And so the question is, how can we reliably diagnose this? And by studying 312 patients, Bruno was able to show that if the monocyte cells in the bone marrow have this CD56 positivity, this is a very strong identifier for this MDS. It occurs in 6.5%, but it clearly identifies the patients who have low blood counts. But this means some very important things. It means that they will not tolerate chemo as well, and also it's very, very difficult to harvest the stem cells and do a stem cell transplant in these patients. And so very, very important to know that right up front, which is now going to be possible. And we know now that these are the patients who might have a poorer survival with a remission of 24 months versus 37, survival of 4 years versus more like 6 years, 47 versus 73 months. And so very important to know that. So this is really an important step forward. If we go to the next slide, slide number 8, this is another abstract about MRD testing, minimal residual disease testing, and this time it's from the Little Rock team with Faith Davis being involved with this particular abstract, number 377. And what she did was she studied 100 patients who had at least a very good partial response, 90% reduction in the myeloma protein. And so at least 50% of those patients are MRD positive. And what she found out is that as treatment continues, the maximum chance of achieving an MRD negative is actually during the maintenance phase. And so this helps to identify at what point should we really be looking to have the maximum chance of MRD. Maybe not after the first 4 months, maybe not immediately after the transplant, but perhaps ultimately at some point during the maintenance, maybe after 1 year of maintenance might be the best chance of MRD negative. So it really sets a helpful time frame. The other thing that they pointed out very clearly is that you need to be quite cautious in that maintenance and ongoing monitoring period, because some patients can have a negative bone marrow, but they could have a positive PET-CT scan indicating that there are lesions or plasmacytomas outside of the bone marrow, maybe in soft tissue and elsewhere. And so that is very important to identify those higher risk patients. If we go forward to, the next slide, which is slide number 9, this is also about the PET-CT scanning, and it's the prognostic value of PET-CT in newly diagnosed myeloma. And this comes from a team that have been very, very focused on the role of PET-CT scanning. This is abstract number 992 from Dr. Elena Zamagni at the University of Bologna. She studied a lot of patients, 718 patients who went forward with transplant. In their protocol, they use 1 or even 2 transplants. And what she did was she looked at how many patients had lesions, the number of lesions that they had, where were the lesions located in the bone marrow or maybe outside of the bone marrow. SUV means standardized uptake value, and that means how bright is the uptake on the scan, so how active is the lesion, and then whether the lesion has bone damage associated with it or not. And so this has a lot of information in it, this particular abstract, but I've just mentioned that in her case, she felt like for the PET-CT, the result before the start of the maintenance was actually the most predictive. At that point in their study, 66% of the patients had a negative PET-CT scan, and those are the patients who had the best remissions and survival. The 44% that were positive did not have such a good outcome, and they were more likely to have extramedullary disease, lesions outside the bone marrow, and have troubles with their ongoing treatment. So if we move forward, there are a couple of slides now, actually 3 slides in total, focusing on something which is really quite new. We have touched on this a little bit in the past, but if you look at slide number 10, you'll see single-cell analysis of circulating plasma cells. And so what I've mentioned in the past is that if you look carefully, you can find plasma cells, or actually myeloma cells, in the blood of virtually all patients with myeloma, and a lot of patients with smoldering myeloma, and even some patients with MGUS. And so what this particular study has done is, this is from a team in Boston, not the Dana-Farber, it's the Brigham and Young and Boston team. And actually, it's a little unusual. These data have already been published, which normally would preclude them from submitting it to ASH. But anyway, it is an ASH abstract. So what I show you here is that it's a small number of patients. They looked at 24 patients, and they were able to identify these single cells in the blood and then study the mutations, including, in different cases, you'll see again that RAS mutations, P53 mutations, the BRAF mutation, which is one that can be important because we have treatment for that. And so this is going to be a whole new way forward to study myeloma in the blood. And so if you go to the next slide, slide number 11, you'll see that this has actually been a big part of the Black Swan project in collaboration with the Spanish team. We have really had a big focus on studying myeloma in the blood because obviously if we have good information from the blood, we don't have the patient going through multiple bone marrow tests. We can monitor using a blood test, and this is called liquid biopsy, and we love that, a blood test, not a bone marrow test. And so this is a collaboration between the Pamplona team and also a very strong molecular biology team at the University in Madrid, and they studied bone marrow and blood from patients with myeloma, basically trying to validate that the cells in the blood, the circulating myeloma cells, the liquid biopsy part, was supporting what is traditionally discovered in the bone marrow. And so on this particular slide, slide number 11, there were 10 patients studied, and it's a little bit complicated, but basically with the red and the blue, they matched up what was found with the chromosomes in the bone marrow and then what was found with the chromosomes in the blood, and they had fantastic matching. And so what this means is that we can get kind of a reliable snapshot of what's going on in the bone marrow by doing the blood test. So that was very reassuring. But there's also the idea that there may be, in addition, some unique features in the blood which could turn out to be even more interesting. And so if you go to the next slide, slide number 12, NGF, so this is the next generation flow. So this is the very, very sensitive flow test for picking up myeloma. And in this case, picking up cells in the blood, a liquid biopsy. And again, they were comparing ways of looking at chromosomes and gene expression in the blood and the bone marrow. And on the left, they were able to find bone marrow evidence for the 414 translocation, and this was also found in the flow assay with the red dots indicating the presence of those same cells with the 414 translocation. And then over on the right, those blue diamonds show that using gene expression profiling, the expression of the genes exactly matched, actually, in a very good way between the blood and the bone marrow. So the bottom line for this is that the circulating myeloma cells are a very helpful and important tool now to characterize the myeloma, to see if there's any myeloma there, and identify what mutations might be there as a basis for possibly selecting the best therapy. So this is, we think, very, very important information for the future. So the future is here now for certain treatments, and so if you go to slide 13, this is where I start talking about what are the new myeloma therapies this year at ASH. And so this first one is something completely new and something that has not even been tried in the U.S., which is very unusual for a new therapy. This is a new study that is being done in Switzerland, of all places, St. Gallen, which is outside of Zurich in Switzerland. And it's a small study, 34 patients, and this was an idea of the investigator there that this AIDS drug called nalfinavir, NFV, it's by mouth. It can have some activity against myeloma, but it really is able to overcome Velcade resistance. And so the combo is NFV plus Velcade dex, well-tolerated, turns out well-tolerated, relapse refractory patients. So those are patients who were progressing with Velcade. 65% had a response. And so if you go to the next slide, slide number 14, you'll see some of those responses were pretty impressive. So those bars along the bottom there, if you look at the right first, so this is slide number 14, abstract number 487, you'll see VGPR, those big black bars, those indicate the percent that the myeloma protein went down. VGPR is 90% or better. So you can see a number of patients had over a 90% improvement in their myeloma protein levels, and a whole bunch of patients had at least a 50% reduction, which is PR. Over on the left, you'll see that there were a few patients, 3 patients actually, who progressed. Most of the patients had at least a minor response or a partial response. So really remarkably encouraging, and I'm sure that there will be a lot of people now wanting to try this out outside of Switzerland and just see how these results hold up. So a really exciting new angle on myeloma therapy. So if we go to the next slide, another exciting new agent, which we have heard about, we heard about this last year. This is slide number 15, and the drug is Venetoclax, not so easy to say. This is a drug coming from Genentech, or a subsidiary called AbbVie Inc. It is a BCL2 inhibitor, which means that it activates apoptosis. It makes myeloma cells go through spontaneous cell death. So basically is a good activator of myeloma therapy. And 66 patients were treated. Shaji Kumar from the Mayo Clinic was the principal investigator. Relapse refractory disease, so these are later patients, and well-tolerated drug. In this case, the Venetoclax was given by itself, and for patients who have this chromosome translocation, the 1114, those are traditionally patients who do a little bit better than average, but when they relapse, you can see here in the middle that the response rate for those patients was 40%. So really a significant response in these relapse refractory patients. And you can see also that the orange is VGPR, and then on top of that you've got CR, dark blue, and then you've got stringent CR, green. And so you can see some fairly dramatic responses, especially in the 1114 patients, but also overall some responses. If we go to the next slide, an abstract to be presented by Philippe Moreau, the Venetoclax, this new drug, was combined with bortezomib dex, Velcade dex, again in the relapse refractory patients. And you can see here that in the combo, some pretty good response rates, and you can see it's broken down with the different categories. Obviously, it was especially active in patients who were not fully refractory to Velcade, although you'll see refractory to Velcade, there's a 24% response rate, 20% response rate if there have been a lot of prior therapies, and so activity even in patients who had been failing on their prior therapies pretty badly. And so a lot of excitement about this Venetoclax moving forward. Next slide. So the third drug, which is kind of new and with strong new data at ASH this year, is the Selinexor, which blocks the anti-oncogenes in the nucleus of the cell. And this is a drug coming from the company called Caregivers. And so on slide number 17, abstract number 491, the results of the STORM trial presented by Dan Vogel from University of Pennsylvania. 79 patients in this trial, and I would draw attention to the fact those 79 patients, 48 were quadrifractory. That means that they were refractory to Revlimid, pomalidomide, Velcade, and Kyprolis, and then penta-refractory, a new group. Those are patients who are also refractory to daratumumab or the Sanofi anti-CD38. So these are patients who are really refractory to all of the major types of therapy that we have. And this is important because the FDA has said to Caregivers that this does qualify as an unmet need group. And so what that means is that showing that you have a good result for those patients, even in a single-arm trial, could be sufficient to justify a submission with a hope of FDA approval. So, 79 patients, response rate 21% in the quad group, 20% in the penta group. So even in the very refractory patients, a reasonable response rate. The duration of response 5 months, the duration of the survival at over 9 months. Low platelets were a problem, also some GI toxicity, some fatigue, and also some weight loss. But this is strong enough data, a strong enough STORM, to justify a larger study, which will be expanded to 120 patients coming up in 2017, and with the idea of a submission to the FDA shortly thereafter. So expect more trial information about the STORM trial as it expands. The next study, slide number 18, Selinexor combined with Velcade Dex. Obviously, Selinexor also works well in combinations. In this case, 977 is what's called the STOMP trial. You'll notice that Michael Kaufman with the Caregivers team, he loves these storming and stomping acronyms. Small study here, you'll see that for patients who are refractory to Velcade Dex, 7 patients responded, which is a 58% response rate with Selinexor plus Velcade Dex in patients who are previously refractory to Velcade, carfilzomib, or even ixazomib. So, again, promising for the STOMP combination. There are 2 other abstracts which I don't have time to get into. One is Selinexor POM-Dex, which I've listed there, number 330. Selinexor carfilzomib Dex, 973, which is one by Dr. Jakubowiak, and he's presented that before. And the Selinexor carfilzomib Dex is a really active combination, and so I'm sure that will be moving forward also. Next, slide 19. This is this CAR T-cell therapy. As I mentioned, what happens here is that the T cells are removed from the patient, go through engineering so that they're teed up to attack the myeloma. They attack the myeloma using a particular target, in this case CD19, which is present on just a small percentage of patients with myeloma have the CD19, but this is a helpful target. The CD19 is actually used as a target in the other hematologic malignancies where it's much more frequent. But the UPenn team have treated 10 patients with the T-cell therapy, which is given as a post-stem cell therapy. It's pretty safe, although there is a characteristic thing which is called a cytokine storm, which means that patients can get really pretty sick immediately in the day or two after the therapy. However, out of the 10 patients, they have had patients that have done quite well. 3 have had some long VGPRs, not complete remissions, but VGPRs. Those are the red lines heading off to the right there. And you can see that those patients are in remission from about 9 months to a little bit over a year. So some longish remissions there with this CAR-T CD19. If you go to the next slide, number 20, the University of Pennsylvania team, this time led by Adam Cohn, who's at UPenn, is looking at a different target. Now, BCMA, this is B-cell maturation antigen, this is present on a majority of patients with myeloma, so this is a much more common target, and so this is something that could be much more widely applicable. Small experience so far, they've treated 6 patients, and so this is a very, very early report. And you can see something here which is quite important. Over on the right, I have 3 columns, and in the middle column, there were 2 patients who had good responses. One stringent CR, and then the other one had a VGPR, which lasted 7 months and 5 months. Over on the left, you'll see the numbers of the T cells that hang around in the blood. And so basically, when the T cells are given, what is most important is, well, how many T cells are there, and do they really get sustained and continue to be active? And so you can see very clearly there that in the patient with the SCR, there were 174,000 of these cells, and so this means that the response definitely correlates with getting a really good CAR-T dose into the patient. Adam also presented a separate abstract, or is going to present a separate abstract using a monoclonal antibody against BCMA again, which could well turn out to be important. So moving forward, for the first time, slide 21, we have a whole session on amyloid treatment. There are actually a couple of new antifibril drugs which are presented. I'm not getting into that. This is just a small point just for you to be aware of, that carfilzomib as a single agent, abstract number 645, does work in amyloid with an overall response rate of 54%. And so as a backup therapy for amyloid, carfilzomib is definitely important, although it needs to be used with great caution in amyloid because of cardiac issues, fluid issues, which are especially common in amyloid patients. So used at lowish doses and with significant caution can be a very important drug for amyloid patients. And then coming towards the end here, slide number 22, diet and MGUS, and this is really quite an interesting study from Iceland, where what they did was they looked at what patients ate early, middle life, and then later in life, and correlated with the development of MGUS, or whether or not the MGUS progressed to myeloma. And what they found out was that a traditional high fish diet in Iceland led to a lower likelihood of MGUS, very good fish. Whereas later on, patients who had switched over and were slipping some meat into their diets were the most likely to actually develop a transition to active myeloma. So really an interesting, kind of a fun study actually, looking at the interplay of diet and how MGUS and myeloma might evolve over time. You can check out the details of that. It gets into some details of older fish habits in Iceland. So finally, some clinical pearls, and these are just a few little tidbits about what are interesting updates to be aware of. And so this is slide number 23. So just to be aware that daratumumab combinations are very active. There are updates of both the Castor and the Pollux studies, all showing very strong results. Also, daratumumab combined with pomalidomide and dex. One interesting side note is that daratumumab was very effective in the treatment of amyloid involving the heart, which can be critically important, and so very, very nice to see that effect there. And quite interesting also, daratumumab can be given by subcutaneous injection versus IV. So very like Velcade, there is this idea to test Dara sub-Q, which could make the whole treatment process a lot simpler and less time-consuming. This abstract is presented by Saad Ousmani. There's also a trial going on with Philippe Moreau in France, but very interesting. Another drug, which is called a checkpoint inhibitor, what we call Pembro, is active in different combinations. There's one abstract there by Dr. Badros. Another interesting point, elotuzumab can be used along with Revdex and can be given as a treatment for high-risk smoldering myeloma. Kind of an early study that from the Emory University team. Several abstracts about free light and heavy light, which are increasingly being focused on for monitoring. To use free light in the blood instead of urine testing. I'm sure that patients will be very pleased to hear that. And then also using a combination of free light plus heavy light can be a very good way to accurately measure the response for all patients. A couple of smaller points. If you do not have elevated free light at the beginning of the disease, it's very unlikely that you will actually have what's called light chain escape later. And so the IFM team points this out, is that light chain escape really only happens in patients who actually did have light chain before. And so if we go to the last slide here of clinical pearls, a small point is that if there is really, really strong uptake on a PET scan, this is not good, and this group from Denmark showed that these are patients who actually have high-risk chromosomes present in the biopsy of a high PET site. Next, just to remind people that we are always having updates, and the updates of Kyprolis combined with thalidomide, Revlimid, and pomalidomide. Obviously, these are very active combos, ones that we've been using now for a few years, and so there are updates to show that these are continuing to work out well, good benefit with those combos. I'll close with a couple of new areas. There are two abstracts about racial disparities. One is showing that HLA typing is correlated with the racial disparity, and then another one showing that racial disparity outcomes are linked in with the diagnostic testing and the therapy that is administered, but actually it was quite encouraging in this abstract from Dr. Alawadi at the Mayo Clinic that given equal diagnostic and treatment intervention, the outcomes were equal for the African American patients. And then a final small point is that there's a new type of dialysis called high cutoff dialysis, which can be much, much better for patients being treated for kidney failure with myeloma. This is a study from France. And so I'm going to close with that tonight. It's been kind of a fast whirlwind, just giving you a flavor of what we're going to be expecting to come out of ASH, and I'm hopeful that this will give you some perspective, a lot of genetic data, which I didn't get into too much, but some exciting new treatment data, which I think will help move things forward for everyone. So thank you, and we're ready for questions.
And you do have a question from Jack Alio.
Good evening, Jack.
Hi, Dr. Durie. How are you?
I'm just fine.
I was wondering if you saw anything regarding transplants that caught your attention.
Yes, I didn't pull those out, but yes, there were 2, 3, 4 abstracts about transplant. One was showing that for certain patients, 2 transplants are better than 1. But what caught my attention for the first time was several looking at a transplant in the relapse setting, showing that transplant, especially for patients who may have benefited before, a second transplant can be a very good option compared with alternate therapies. So, yes, several good abstracts on transplant, actually, yes.
Thank you.
Okay.
Your next question comes from Thomas Tucker.
Yeah, hi, Dr. Durie. I'd like to know if you know of anything else that's been looked at sub-Q besides the daratumumab. That's exciting, and I was just wondering if there's some other ones that they've been doing by IV that now are looking at sub-Q.
Well, no, really. So this would be just the Velcade and now the daratumumab. Carfilzomib, Kyprolis cannot be given sub-Q, so that the switch there is to oral, so that and it just depends on the formulation, so that there are these oral proteasome inhibitors. You've got the ixazomib, and then there's also a form like carfilzomib being developed as an oral. So yes, so the main ones are just these two, which are sub-Q, and then the others are actually oral versus IV.
Thank you.
No problem.
Your next question comes from Tricia Marquardt.
Oh, Patricia Marquardt, that's me.
Hello.
Hello, Dr. Durie. I'm sorry, I did have to come in about 10 minutes late, and I wanted to ask a question about the MRD, one of the early points about the MRD.
No problem.
And the strong support for black swan concepts, because I keep getting conflicted opinions about that you need to become MRD negative. And
well,
and that some people some doctors that are very well respected that seem to think that that's irrelevant because those studies, this is what I've heard from them, are not that good.
Sure. No, this is really, really good feedback, and it is pointing out that this is research that we're doing, and what we've identified is that the very best results appear to be in the patients who do get that MRD negative, so that if you have your first therapy, your transplant, and then your maintenance, and this is true for about 50% of patients, then you get that MRD negative, this gives your best results. But we've also learned that if you look at long-surviving patients, quite a lot of those can be MRD positive. And so there's a subset, and a very, very important subset of patients who are MRD positive, and we are in the process of studying them to see, well, why is that? What is it about the myeloma? And more importantly, what is part of the studies now is what has happened to the immune system in the bone marrow and elsewhere to maybe control the myeloma. And so this is a very, very important subgroup of patients where there can be residual myeloma, a positive MRD test, but the immune system is tuned up in such a way that the myeloma is controlled. And this may be with natural killer cells or with T cells of some sort. And so this is an important part of the ongoing studies. But you see, maybe the difference of opinion I might have with some investigators is that this is definitely something that we need to study. We're not saying that MRD is the top thing for every patient, but it's certainly important for many. And the MRD positive patients who do well, we need to study that as well.
Okay.
I hope that helps.
All right. That does help because first, it's me, obviously. I'm the patient, and nothing showed up in my
I mean, maybe the final point for you as a patient is that we are still learning. Let's say your test is negative. What are we going to do about that? Well, we are still not sure, if you're on maintenance, just because you get a negative result, should we stop at a particular moment, or should we continue with our regular plans? And then again, if you're MRD positive and you're doing well, do we need to give you new treatment or something like that? So we need to be investigating these as part of studies and trials right now, because one perspective is that we can't exactly guide you right now because we don't know enough. Okay?
Okay. All right. Okay, then I will wait and see, and I'll just keep checking in.
Yes, I think that's a frustrating thing, but we are learning a lot pretty fast. This is moving very quickly.
Okay. Thank you very much.
Your next question comes from Denise Go.
Hi, Dr. Durie. I was wondering if there was going to be any presentations done on studies from MM centers that are doing work with oncolytic viruses like measles and the other viruses that they were looking into.
Very limited this year. There's a little bit of data linking receptors for measles to the presence of the P53, so that maybe the measles might work in resistant myeloma, but the main study, which is with the measles, which is from the Mayo Clinic, there isn't any presentation on that. And then the next one that they're starting at Mayo, which is with the VSV virus, the vesicular stomatitis virus, they're just getting started with that, and so there's really no data on that presented. So this is an exciting area with those oncolytic viruses, but really not much to report from ASH this year.
Okay, thank you.
Mm-hmm.
Your next question comes from Bonnie Talbot.
Hi, Dr. Durie.
Hello.
Hello. Can you just clarify a little bit more about the liquid biopsy? Do I understand you correctly that the first use of it would be the correlation with chromosomal abnormality, but it wouldn't really suffice to for load, for percentage?
To assess the amount of the myeloma, So we're investigating that right now, and I'll tell you 2 or 3 things that we're doing and other people are doing. That this area of myeloma in the blood has become a very active area. So the first thing is, let's say with the standard approach that we have right now, you do the MRD test in the bone marrow. Let's say you have a complete remission, and then we do the MRD test, and then it's negative. So one of the most cumbersome things is, well, how are we going to monitor you? Are we going to keep doing your bone marrow every few months to see if you're still MRD negative? Because we do need to track it. And so what we're looking at is to use the blood to monitor a patient like that, where every 3 months or every 6 months. And what we know already is that in a patient who might be relapsing, those cells show up back in the blood early, and so monitoring in the blood for an MRD negative patient, so for a patient who's MRD negative in the bone marrow, you can then track them with a blood test, and then it's early enough and sufficient to get these early changes in the blood. And the really important thing is that not only can you find that little bit of myeloma in the blood, a single cell you could pick up, but you can tell, does it have these RAS mutations or some other kind of mutations? And so this can be very helpful as a basis of converting MRD positive to MRD negative, so that it's really important to understand the types of cells with the chromosome abnormalities and the like that are contributing to relapse, to resistance to MRD positive, and then come up with the best therapies for that MRD positive. Are you with me?
Yeah, that's it.
The other thing, the other area where it's important is for smoldering myeloma, where cells in the blood indicate active smoldering. So we're looking at that as well. Okay. Thank you.
Thank you.
Your next question comes from John Tordiro.
Yeah, you can just call me John T. Dr. Durie, thanks for the presentation. I'm looking at the response rates on page 16 with the Venetoclax, bortezomib, and Dex. How do these compare with some other combinations used in the relapsed refractory setting, like Kyprolis, Revlimid, and Dex, or Dara?
Yes, I think that they're really they're pretty excellent. I mean, I think that these are good, and so I think that now there are going to be some comparative trials to really answer that exact question that you're asking, and it's kind of a generic question that we have right now where, as you're pointing out, so now we have Venetoclax, bortezomib Dex, but as you know, we have daratumumab, Velcade Dex. We've also got carfilzomib, we've got ixazomib, we've got all these different combos, and so I think that it's become rather difficult to make these comparisons because many times the patients who are coming into these trials are slightly different, and sometimes they're blinded and sometimes they're randomized in different ways, and so it ends up being difficult to compare, and so this is a challenge, and it's actually something that the working group is kind of looking into to try to help sort this out and come up with some guidance.
Yeah, the other thing I see is that if these people are refractory to one of the drugs, that may influence the choice of what therapy they use.
Exactly, and so someone might be inclined to maybe not use that combination, but maybe to use a combination for a drug that they're not refractory to, for example, right?
Yeah. Okay, I'm getting it.
No problem.
Thanks so much.
Yes. So I think we have time for one last question.
Your next question comes from Leah Cohn.
Hey,
Hello,
thank
Leah.
you very much. Hey, I was wondering if there's any information about how often PET-CT should be repeated. If you do find that there's progression on PET-CT, but the blood, for instance, is negative, so you have discordant results for MRD testing, the PET-CT is positive, the blood is negative. How often do you do that? It's not the kind of test you can easily do every month.
Right. So this is a very tricky area. It's a very important question. I mean, I think ideally, and in Italy and in Bologna, you'll see these studies are coming out of Europe, Italy and Germany. It's a lot easier, and it's covered through the healthcare system to get these scans done. You would want to do a PET-CT scan at least, once a year, for example, but as you're probably aware, through Medicare and the like, they will only reimburse a certain number of scans. And so scanning is really helpful, but it's one of the reasons that we're looking for these other tests. So if your PET is negative and your MRD negative in the bone marrow, we know that you're in pretty good shape. We might end up monitoring you with a blood test, like this myeloma cells in the blood. So we're looking for ways to kind of work around this because PET scans are great, but the reimbursement and the availability is not so great. So it's a tough one, that really, because there's a difference between what we would like to do and what we can actually do. So sorry about that. Yes.
Thank you.
Okay. All right. Well, I think that we're going to have to close there, but hopefully this is not a complete report about ASH, but hopefully gives you a flavor of what we're expecting, and we'll definitely be reporting back. Maybe there'll be some surprising and additional things that we discover in these presentations.
So this is Susie Durie, and before everybody starts hanging up, I just want to tell you a couple of things that I think are very important, and I want to thank Robin for reminding you. There's, at the ASH meeting, which of course is going to be taking place in December in San Diego, there are two very, very important symposiums that will be broadcast live. One is our ASH symposium that takes place on Friday, and if you go to our website, you can get the link to that. It's ashsymposium2016.myeloma.org. And the other important event that's taking place, there's so much going on, is the
IMF conference series, Making Sense of Treatment. That's a really exciting one where Dr. Durie, along with two of his colleagues, will really kind of duke it out about all the different opinions and so forth. It's very lively and it's also very informative. So those are two very important things. There's a lot more going on, and if you go to our website, you'll find more information there. But Brian, I want to thank you. That was really great and very informative, and I'm sure everyone on the call tonight really appreciated the information, and as you mentioned, there's a lot going on. So I'm sure that some of you will have a lot of questions, and so I suggest you call our info line. They'll be able to help you. The info line is open from 9 a.m. Pacific Standard Time to 4, and the toll-free number, for those of you who don't know it, it's 800-452-2873. Another really fantastic way to stay abreast of all the new data and how it impacts your treatment is to go to our new and much improved website. There's a wealth of information there, and our new site is easy to navigate. You might also want to register for our next Patient and Family Seminar that will take place on March 17th and 18th. It will be here before you know it. This one will take place in Boca Raton. And as I said, time is flying by. We'll soon all be in Boca. And I'd also like to thank our tonight's sponsors, Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. And before we close, I want to thank our wonderful support group team here at the IMF. Obviously, Robin, Kelly, Nancy, Sue, and Ann. And they work with groups all across the country and are there to help you in so many ways. If you don't belong to a group and would like to join one, call our info line and they'll tell you if there's a group near you. So that's it. Thanks, everyone, and have a very happy Thanksgiving.
Yes. Thank you all, and good evening. Have a good evening.